Okay, so this is the case study for GR. GR is a 58-year-old male. His medical diagnoses are GERD, hypertension, and obesity. His communication diagnosis is a moderate to severe dysphonia, characterized specifically by roughness and strain. So his complaints are mainly of a hoarse voice with a lot of vocal effort. Other relevant information related to our client's background: he owns a popular restaurant, so he works in a very noisy environment. He lives at home with his wife, and his wife and him eat at least 2 meals at the restaurant 5 to 6 times per week. He was referred to the clinic by an ENT to trial voice therapy before surgery for GERD. The report in the referral showed irritated supraglottal tissue via stroboscopy. So our client's case history. So starting off with voice history, our client noted that he had problems with reflux since his late 30s, but he typically just took Tums and his symptoms went away. His reflux symptoms worsened throughout the years, and he was diagnosed with GERD at the age of 40. Since then, he has begun taking PPIs to treat his reflux symptoms as prescribed by his physicians. He noted that he did not have any noticeable vocal symptoms or throat discomfort until about 2 months ago. So because of that, he has not received speech and language services prior. His voice symptoms he reported that they worsened severely in the last 2 months. He notes that his voice does change throughout the course of the day, worsening as the day progresses, which makes sense with peak hours being lunch and dinner time at restaurants. He notes that on holiday weekends, when the restaurant becomes busier, he notices that his voice will give out and he will lose his voice. As for physical symptoms, he reports that his voice hurts. Typically, as the day progresses, it hurts more and more, and he just waits for it to go away, so going to sleep, and then reports that it will be gone the next morning. When asked to rate his pain severity on a scale of 1 to 10, 1 being slight discomfort and 10 being the most painful, he rated his pain as a 6 to 7. His medical history, so he has not had any major surgeries or illnesses. He doesn't have any other diagnoses than the ones listed, so obesity, hypertension, and GERD. He reports that his heartburn is the worst at night after dinner, so he feels the feeling of throw up in his mouth when he's lying in bed at night specifically. He reports mild trouble breathing, but he does not have an asthma diagnosis, and he's recently begun receiving treatment from his PCP for GERD through the prescription of PPIs, and he says that he still sometimes will take Tums, especially if he's working and does not have his prescription with him. In terms of psychosocial history, on a scale of 1 to 10, 10 being very confident, when asked how confident the client feels in his voice, he reported a 3. He does not feel that his voice aligns with who he is, and he has lost confidence in his voice and himself because of his vocal symptoms. His vocational voice demands, so as mentioned before, he owns a very popular restaurant. As the restaurant owner, he is required to use his voice consistently throughout the day and night, especially more so during peak hours when he has to yell and speak loudly in order to get information across to his coworkers who are located throughout the restaurant. In terms of interpersonal case history, he frequently socializes with his friends, including weekly poker games. He also has weekly family dinners and reports that his coworkers and friends and family have a hard time understanding him towards the end of a busy workday. In regards to his lifestyle, he smokes a pack of cigarettes every other day, and on top of that, he smokes a cigar weekly with his friends. He drinks 4 to 5 cups of coffee per day and drinks alcohol socially every week, and he also has a large cup of soda at least twice a day. His diet consists of mostly tomato-based foods, as that's what his restaurant serves, so a lot of pizza and tomato sauce, and he reports adding a lot of hot sauce or hot spices to his meals as well.
GR's main goals are to sleep comfortably, to project his voice at work in a more efficient and effective way, to decrease his throat discomfort, and to increase his vocal stamina. Diagnostic hypothesis. Upon analysis of referral information and case history data, our diagnostic hypothesis includes dysphonia caused by smoking, dysphonia caused by vocal fold hyperfunction, and dysphonia caused by GERD. Additional hypotheses include vocal pathologies such as nodules, polyps, and cysts resulting from hyperfunction. Video stroboscopy is needed to confirm the presence and/or severity of a pathology. Materials and procedures used were the video stroboscopy, the EGG, the VHI, an objective voice assessment, and a subjective voice assessment, plus the CAPE-B. Data and interpretation. Initially, based on client case history and the referral by the ENT, clinicians had suspected smoking to be the primary cause of supraglottic tissue redness and irritation. However, further analysis revealed more concentrated redness and irritation in the posterior portion of the larynx. This is attributed to GERD and is a causal factor in the client's throat discomfort and vocal fatigue. When performing the video stroboscopy, the pre-treatment data suggests that he has irritated supraglottal tissue. The comorbid presence of hypertension and vocal fold tissue redness and irritation is indicative of his smoking history, and the presence of posterior supraglottic tissue redness and irritation is indicative of his GERD. It is also showed an excessively long closed phase indicative of hyperabduction and of the vocal folds. The post-treatment data suggests that his decreased supraglottal tissue redness and irritation compared to the initial video stroboscopy. This suggests that it may be attributed to the reduction of smoking behaviors and decreased severity of GERD symptoms, particularly the reduction of posterior redness and irritation. Also, the decreased length of closed phase indicating decreased hyperabduction of the vocal folds. The EGG. In the pre-treatment data, the EGG waveform showed irregular vocal folds, abduction and abduction with longer closed phase, which is a characteristic of dysphonic voice. And the post-treatment data, the EGG waveform showed decreased close to open ratio, indicating decrease in the vocal hyperfunction. His VHI has a pre-treatment score of 50. GR reported moderate to severe physical effort and moderate emotional distress and impairment as a result of his dysphonia. In his post-treatment score of 5, GR reported improvement with a mild physical effort and emotional distress as a result of his dysphonia.
For the CAPE-B, prior to treatment, we found GR's dysphonia to have an overall severity of moderate to severe. Prior to treatment, he demonstrated severe roughness, within normal limits breathiness, severe strain, within normal limits pitch, and mild to moderately too loud volume. However, post-treatment, GR demonstrated within normal limits behaviors across all categories, including roughness, breathiness, strain, pitch, loudness, and the overall severity. For the subjective assessment, the pre-treatment data is listed in the middle column and the post-treatment data is listed in the far right column. Prior to treatment, his resonance in speech was found to be laryngeal. He demonstrated glottal fry at phrase and sentence endings predominantly. He demonstrated hard glottal attack and within normal limits speech rate, vocal stability, and intonation. Prior to treatment, he demonstrated thoracic breathing at rest, thoracic and clavicular breathing during connected speech, shallow inspiration, and effortful and forceful expiratory patterns during phonation. However, post-treatment, he demonstrated laryngeal resonance, glottal fry at phrase and sentence endings predominantly, but then demonstrated balanced glottal attack and continued to demonstrate within normal limits speech rate, vocal stability, and intonation. And post-treatment, his breathing patterns shifted. After treatment, GR demonstrated abdominal and diaphragmatic breathing, both at rest and during connected speech. He demonstrated inspiratory patterns of appropriate depth during speech and expiratory patterns that were appropriate during speech as well, following treatment. Continuing with our subjective assessment, prior to treatment, GR demonstrated aligned posture, and at rest, shoulder position was symmetrical and relaxed. However, during inspiration, shoulders were elevated, and this is consistent with the pre-treatment behavior of clavicular and thoracic breathing. During speech, shoulder positions were symmetrical and relaxed prior to treatment. Head and neck position was level. Facial features were within normal limits. And prior to treatment, lips were relaxed during speech but pursed at rest. And then mandibular positioning and movement and tongue position and movement were all within normal limits prior to treatment. Following treatment, posture was aligned, shoulder position shifted to be symmetrical and relaxed at rest during inspiration and during speech. Head and neck position remained level, facial features remained within normal limits. Lips shifted to be relaxed consistently, both during speech and at rest. And mandibular and tongue position and movements remained within normal limits. For the objective assessment, while there were some changes observed across habitual phonation, sustained vowels, and connected speech and monologue tasks, the most notable observation we found upon analysis of our data was in the total range of semitones, and that is where the greatest change occurred. Prior to treatment, as you can see notated in the black text, pre-treatment values are notated by black text, GR initially demonstrated a total range of semitones of 4 semitones for the rainbow passage and 9 semitones for the monologue. However, post-treatment, those expanded to 15 semitones for the rainbow passage and 20 semitones for the monologue. And it's worth noting that while this is still lower than the normative data for males in this age range, as you can see in the bottom left corner of the table, this is still a shift from pre to post treatment, so it is indicative of improvement following treatment. And for the most notable data point on this table is found in max phonation time. Initially, GR demonstrated a max phonation time of 17 seconds. However, following treatment, that was expanded and it became 23 seconds for the max phonation time. And while changes are seen in the frequency range of phonation, the max phonation time demonstrated the greatest change in this table. Now moving to our differential diagnosis, we concluded that for the communication diagnosis, GR has moderate to severe dysphonia resulting from GERD and smoking behaviors, and this moderate to severe dysphonia is exacerbated by compensatory vocal fold hyperfunction. And during the assessment process, a newly printed and smudge-free report was received, and this report stated that the medical diagnoses for GR include obesity, hypertension, and GERD. Bearing all of our data and results in mind, these are the approaches we avoided for this client. We avoided effort closure because this could have been harmful given the client's vocal fold hyperfunction, and we didn't want to facilitate behaviors that would lead to further hyperfunction that would damage the voice. And also, effort closure may have been painful given the client's supraglottic redness and irritation that we observed in our video stroboscopy, so we avoided effort closure. We also avoided vocal rest as an approach because for this particular client, it wouldn't be functional and it wouldn't be feasible given his occupational and social vocal demands.
On this slide are listed GR's treatment goals. The target goal areas will include client education about vocal hygiene and vocal conservation, client education about reflux management with regards to the voice, diaphragmatic breathing, and general tension reduction. The goal, as noted, there are multiple goals on this slide. So in this presentation, it will be divided up into 3 separate categories of hyperfunction, vocal demands, and reflux management. So to first address the hyperfunction, the first treatment technique we decided to use for GR would be Yonsei. Yonsei is a treatment technique designed to reduce laryngeal hyperfunction and hard glottal attack. More specifically, it works to lower the larynx during phonation and maintain a relaxed vocal tract, as the larynx is typically elevated in individuals with vocal hyperfunction. For this reason, it is an appropriate technique for GR, and the steps of Yonsei are listed as below. The second approach we would use to address hyperfunction would be chewing. In this technique, chewing is used with this client, This technique is used with GR due to his hyperfunctioning behaviors. Chewing is a common method used to reduce hyperfunctional phonation because patients, while chewing by nature, produce a more relaxed vocal tract. For this reason, clients are taught to practice vocalizing while engaging in chewing motions. The motion of chewing is then gradually faded as a client habituates speech productions with relaxed phonation, and the steps for this treatment are listed below. The last approach we would use to address GR's hyperfunction is a suprahyoid massage. This technique is used with GR due to his tension and hyperfunctional behaviors. This is a common method utilized with clients to improve vocal quality, reduce vocal fatigue, and increase self-awareness related to tension. We chose this procedure due to GR's ability to administer the massage should he feel any tension in his voice throughout the day. The steps to administer the massage are listed below, and the 3 techniques listed target goals 2, 3, and 9 on GR's treatment goal plan, as each is designed to reduce his hyperfunctional behaviors that result from his high levels of tension.
To address vocal demands, clinicians educated the client regarding vocal demand, vocal hygiene, and how his current vocal behaviors affect his voice. Clinicians also explained the importance of using proper diaphragmatic breathing during phonation. Throughout therapy, the client used diaphragmatic breath in tasks which increased in difficulty with a criterion of 80%. An option to assist with vocal demands is a voice amplification device. Given that the client spends his days and nights in a busy restaurant, an amplification device would likely be beneficial because it synthetically decreases the distance between speaker and listener. Clinicians educated client regarding device options, costs, in which context to use device, as well as other options to improve voice conservation. To minimize irritation and discomfort resulting from GERD, clinicians provided client education to facilitate understanding of the relationship between GERD and the voice. This included avoiding spicy and acidic foods, waiting for food and beverages to digest before lying down, hydrate and avoid caffeinated beverages, continue reflux management medications, over-the-counter and prescribed medications. GR initially presented with moderate severe dysphonia resulting from GERD, smoking, and exacerbated by compensatory vocal fold hyperfunction. Intervention targets included patient vocal hygiene education, patient reflux management education, direct facilitation targeting vocal hyperfunction, and techniques targeting vocal demands. Following 12 weeks of weekly voice intervention, although GR still showed mild to moderate semitone restriction for connected speech, GR showed improvement in vocal quality and demonstrated within normal limits roughness, breathiness, strain, pitch, and loudness after treatment. His reported emotional distress decreased and he is now satisfied with his voice. Prognosis is good given consistent attendance of therapy sessions, consistent completion of homework, and decision to quit smoking forever, per client self-report. It's recommended that GR continue GERD treatment in conjunction with primary care physician and that he use assistive technology such as amplification devices and earpieces at work. It is recommended that GR contact the clinic if any questions or concerns arise.